All right, you are the host officially.
Oh, so much power.
I'm going to leave you.
Yay.
Don't sound so excited.
Good weekend.
You too. Bye.
Well, good morning, good afternoon, wherever you are. Good evening.
Good morning.
Wow, good. Somebody responded here. And that was you, Andres, I think. Yeah.
Yeah,
Let
that
me
was me.
get my computer organized here, and then we can start. So I know that, Dr. Mishlak is going to hopefully join us in a few minutes. She, I know, has a case. If she doesn't have a case, I can talk to you about the case we did on Wednesday. But I'm hoping that somebody else has a case or something to discuss. Hoping.
I had a lily intoxication, but nothing that impressive.
Did it get better?
No, actually it didn't. It didn't get worse, but it didn't get better until it dies.
Did it die?
Yeah. But the thing is, it kept stable all the time. Creatinine stable, everything stable, but eventually he died.
You dialyzed it?
I tried, but he died before that. Yeah. I had everything prepared and just died while we were connecting and everything.
Huh. And how uremic was the cat?
6 creatinine and 200 something BUN, and it kept that same value for almost 2 weeks.
Yeah, that's interesting. The reason that I'm curious about this is because I think we don't have a good understanding of what the prognosis is for Lily. I mean, in the literature, it's mostly suggesting that, about only about 40% of these animals survive. I think my experience with it has been better than that. At least then, again, I didn't search our records. I'm just thinking anecdotally, but I always thought Lily was a better prognosis than that, but perhaps it's not. And the other thing that your case points out is, for all these uremic patients, you really have to get them early. 6 days of a 6 creatinine and 200 BUN, that patient's going to have a lot of recruitment of a lot of other disease events that make the outcome better. And for any of you that have been in the academy, Dr. Francais discusses this. And, once the creatinine gets to about 4, and we used to say once it gets to 10, start dialyzing. Well, we've really reduced that number down now, and about at creatinines of 4, that's when you should start dialyzing, because if you wait, then you just recruit a bunch of pathophysiological events that you can't recover from oftentimes. So that, and I don't know the circumstances of, the 6 days that the cat was uremic before you tried to dialyze it, but
Yeah, that's the thing
it's
that
a nice
surprised me.
example. It's not a nice example, but it is an example of you really you really struggle when the animal's been uremic that long, and we should intervene with dialysis at a much earlier time point. And maybe 4 might even be too late in some cases.
Yeah, that's the thing that surprised me the most with this cat, because he was really well all this time. He was sitting by um, by himself. He was producing enough urine. He was a little bit hypertensive, but not too much. He had a severe anemia. he entered with, I remember, 12 hematocrit, something like that, 12%. And we kept transfusing him. He did hemolyze all the transfusions we gave him with cat blood. That was the thing that surprised me the most, because we run out of cat blood, and then we use dog blood, and that kept him stable with a 34 hematocrit for almost the the longest period of time he was in the hospital. Yeah,
Hmm.
it was
Did,
interesting case.
did you type the cat?
Yeah, yeah, absolutely. And all the blood we gave him was compatible, and it surprised me that the red blood cells of the donors didn't last too long.
Well, it's curious too, because I think a 12 hematocrit for a lily toxicity, that's a little unusual. I don't think we'd expect that unless the uremia, the cat was bleeding. I mean, an AKI is usually characterized by, a fairly normal hematocrit, sometimes even an increased hematocrit if they're dehydrated compared to chronic kidney disease. So was it potentially an acute on chronic?
I don't think so, because his ultrasound was really good. His kidneys had a good cortical to medullary ratio. The thing was, they were really hypercoic, and probably he arrived with me a little bit too late, because I think he was in another hospital for 2 or maybe 1 week before he arrived with me. I suspect it was an erythropoietin deficiency, because he responded well with the erythropoietin, and there was no signs of bleeding and nothing else, no signs of chronic kidney disease. He was a young cat, a 5-year-old. So that was interesting. Yeah.
It would have to be bleeding, I think, because an erythropoietin deficiency would take weeks to show up. Those red cells have a half-life of 100 days, and when that 100 days is up, when we're treating animals with erythropoietic stimulating drugs, and they get to the end of the efficacy period of the drug, then we'll often see a big drop before they're going. But you don't see within a week or two, you're not going to see a big profound drop in hematocrit from erythropoietin deficiency. You're not making new ones, but the ones that are there will survive for a long enough period of time. Then the way I always look at it, all those cells, when you give an erythropoietic stimulating drug, all the new cells have the same birthday and they have the same life expectancy. Then they all die on the same day, when their half-life runs out. And so it'll go and it'll go and go, and then you get a very profound plummet in the hematocrit. But that takes a couple of weeks. That takes about 3 weeks or 4 weeks before you see that, in my experience.
Well, I don't know how much time before he arrived with us he was sick, but probably it was at least 2 weeks, maybe even more, right?
Yeah, well, that's 14 days. That's 2 weeks is 14 days, and those red cells are going to live long. They're not going to live a normal lifespan in a uremic environment, but they probably live a month, I would suspect, at a minimum. Even when we transfuse chronic kidney disease patients, those cells last a few weeks. Typically, they don't last normally, but I've done a lot of research with erythropoietin, and those cells last longer than a couple of weeks when the cells that get stimulated.
So, do you think maybe it was bleeding before it arrived with us? Maybe.
I think bleeding is probably the most likely cause for an hematocrit of 12 and an AKI. Would be my perception.
Yeah, I agree with you. Thank you.
Good morning, Jethro.
Well, good morning.
And we got Simona. I want to introduce Sarah Mishlak, who's a new extracorporeal nephrology urology resident at Davis, and she's going to be a star. You guys just watch her. She's going to be a star in nephrology urology. But we had a case together on Wednesday, a cell collection, and so I'll let Sarah go ahead and discuss that, and then if we have time for some other ones at the end, you guys can bring those up. And I
Nice to meet you all.
I have to give you permission to show your slides, probably. If you made some slides, I don't know if you did or not.
Right. I don't have, but I can can you guys hear me okay?
Yeah, great.
And hi guys, it's Carrie too, Carrie Palm. I miss you. I can while you're doing that, I can pop a few pictures of her and stuff while you're talking, so I can show that. So you go for it.
I've got some here too, if
Okay,
you need to illustrate something.
That would be awesome.
Okay.
Yeah, I have them on my phone still.
And we also did another ibuprofen tox that got intralipid, so we TPE'd her, so we have her too to talk about. We did her last night.
You did TPE on an ibuprofen?
Yeah, she got intralipid before she came in. But anyway, I will let Sarah take it away.
All right, we can I'll talk about Jack. And just correct me, I have not been to one of these, so I'm not sure the exact, but I'll just present it like a normal case and then discuss our procedure. But Jack is a 7-year-old male castrated lab mix who was diagnosed with osteosarcoma of his right pelvic limb in early July, underwent a limb amputation in late July, which confirmed on histopathology that it was an osteosarcoma. And then his owners did a lot of kind of self-research, were really motivated, and decided to pursue the Elias cancer immunotherapy treatment, which involved first them removing or taking his tumor tissue, and then the company forms that into a vaccine, which he received, I believe I think it's 3 doses intradermally over the period of a few weeks. And then he came to see us earlier this week for mononuclear cell collection. And then those lymphocytes that are collected, which we'll talk about the procedure in a second, but those the product that we collected were then shipped up back to the company, hopefully have arrived, and are going to be treated with a T cell stimulator or activator, and then he'll receive that product back as a transfusion, and then undergo 5 IL-2 injections, with the goal of kind of using his own tumor and then his own T cells as an immunotherapy treatment. So I think this is my first time being involved in one of these cases, and really honestly reading about it. I think a really, really cool modality. And then we got to be a part of the mononuclear cell collection. So
let me
Jack
just
came in,
explain.
Oh yeah.
So the purpose of this therapy is you collect after the vaccination, you generate a series of antigen specific adoptive T cells, and these are T cells that have been programmed to recognize the very unique antigenic determinants on the surface of the cancer cells, which will be different than the receptors on the surface of normal osteocytes. And then those are the cells that we collect after the vaccination protocol, and then they're jazzed up to make antigen-specific adoptive killer T cells that get infused back into the patient, and then those cells can go out, try to find any residual cancer cells that may be roaming around, and attach to them and kill them off.
Yeah, it's a really, really cool. So Jack luckily had been doing really well post amputation, and prior to seeing us, So we just, met him and did some pre-anesthetic, pre-procedure blood work, which looked really good. And we were pretty happy to see he had about 2,000 or so, or 1,500, I think, circulating lymphocytes. So more than our average. Many of our patients, that have stress leukograms, they're really low. So we were happy to see that to start with. So then we moved forward with his procedure, and the mononuclear cell collection we performed on our Optia. And we had the extra fun of having to work a little bit with the machine as the AIM system, our camera is broken. So we can talk about some of the adjustments that we made during that treatment in order to establish our interface and collect the targeted cells. So we placed for him, he was I should have said he's like a 45 kilograms, so a really big lab mix, 45 kilogram dog. And so for his extracorporeal catheter, we placed an 11.5 French 24 centimeter catheter that we felt would be very adequate, allow us to reach the blood flow that we needed. And it definitely worked well. And then we basically, hooked him up to our machine. So we got him on the Optia after priming, and then I'm sorry, I don't know exactly how much detail to go into, but his once he was bled onto the machine, his blood goes through, is taken off, goes through a series of pumps, which I do have some pictures of his actual setup. I don't know if we want to show that to go through kind of the parts of the saline and ACDA going in, but his blood is then moved through a series of tubing systems, including like a clot catcher, then down into the centrifuge, where it's separates out the red cells, and then kind of our buffy coat layer, which is going to be from our red cells going up to the plasma will be our red cells, then our granulocytes, monocytes, lymphocytes, platelets, and then plasma. What we were doing quite a lot of at the beginning of the procedure was trying to establish our interface, so that our collection tubing was our collector right at the buffy layer that we were trying to collect from, so that we were not just removing platelets or just removing plasma or red cells from him. And that took probably ultimately about maybe even up to an hour for us to we started how we entered his close to his actual packed cell volume to help try to establish the interface, but then we were finding that we were really going in both directions. For a little while we were just collecting red blood cells, and so with the camera being broken, which would normally allow us to use our AIM system to set our collection preference, so kind of how deep or how shallow we were collecting within this connector system that's viewed here, that was broken. So instead, what Dr. Cowgill had established with our team last time when they had a dog on the machine when the camera went out, was that we could sort of trick the machine into basically setting our collection preference by altering the input to our machine's hematocrit. So kind of regardless of what Jack was doing on the machine and where his PCV was holding, which it was holding right about 40%, we would make adjustments so that if we wanted to drive deeper into our red cell layer, so there was a time in the procedure for about 5 minutes or so, we were collecting just plasma, then we would reduce the hematocrit that was entered into the machine, which would then try to establish and collect deeper in towards the red blood cell layer, which obviously is not what we were going for, but just to move deeper, equivalent to setting a lower collection preference if we did have our AIM system. And then when at times, like at the beginning of the procedure, when we were just collecting mostly red cells, we would go into our system, into the Optia, change the hematocrit that we entered to a higher hematocrit, which would then sort of drive our collection towards the plasma. So that's pretty much were the adjustments that we made, mostly using the hematocrit input over and over for that 6 hour or so period to maintain our collection where we wanted it, with the added fun of Jack being a supremely anxious dog who would sometimes try to be jumping off the table and barking, and then get some sedation and then really settle, which was definitely, we were seeing in real time his hematocrit changing probably within him before our eyes, and adjust why we were having to make so many adjustments.
Yeah, that's great. Maybe I can just, since I've got these pictures up here, I just grabbed, so this is the connector. This is where the cells, where everything happens here. This is the channel that is going to bring up the cells. And what you really have to try to fight with is to get, and those cells are going to be collected right at this little, kind of in this little plateau area right here. That's where this opening comes down to collect those cells. And the cell types that you want to collect, you kind of got to get into that range. And ordinarily, there's an adjustment on the machine that you can say, what we're trying to do is to establish the interface. And so the interface is this layer right here that's between the blood cells and the plasma. And you can see in this situation, almost all of this is plasma and platelets. And then there's a wispy little bit of blood down here at the bottom. So that's where the interface is really, really low. And all you're gonna pull off then are just platelets and plasma. And while we're established, and usually it's easier to do that, but when your machine is broken, then it's a little bit harder to make these adjustments. But during this phase, you can return all of this product back to the patient so that it doesn't go up into your collection bag and contaminate your bag. Then the opposite situation is this, where you can see the interface here is really, really high. That means you're going to be collecting fairly low. And what I might suggest, so you can see here's a plasma layer, and this plasma's got a lot of platelets in it. The buffy coat is the layer between here and here. And you can see this really dark area on the bottom are the red cells, but there are red cells distributed all through the buffy coat. And that's how you recognize where you are, is the color of the product that you generate. And when you get the interface just right, which is illustrated in this one, I'm sorry, not that one. In this one, you can see now we've got, and this kind of opacity that you see here, the platelets are kind of swirling in the plasma. We've adjusted the interface so it's at the level that we want, and now you can see we're actually collecting some cellular material. And then all of that is indicated. Let me just bring one more little picture over here, and that's not a good one. Let me bring this one over. And so you're looking at the color of the product. So this is the cell product that's going to go up in your collection bag, and you try to match that product to this color chart. And the reason that there's color in here is because the white cells are contaminated to a varying extent, depending on how high or how low you are in the buffy coat, with blood cells. And this, usually the lymphocytes kind of live right out at about this color. And I think I had a picture that showed it a little better. This one we would say is a little dark. So it's collecting lymphocytes, but it maybe also is collecting cells that are a little bit lower than the lymphocytes in terms of their density. But this is what you really use to gauge your depth of your interface and your collection region when the machine doesn't work, when this AIM system, which does it more automatically, is broken. Just for those of you that hadn't seen that before.
And I think one,
And then,
go ahead, Mish. No, you go. Go.
to talk about the product that we ended up receiving too. So if you have anything else about the procedure. Go ahead, Dr. Paul.
No, I was going to do two things. I was going to actually share a screenshot of what we got, but then I just thought some other good things that I think are always interesting is, we always talk about some of the.
Go ahead, Carrie, and show that. I'll stop sharing.
Oh, thanks, Dr. C. I will. I was also just going to say, which I always think is good to talk about too, is discussing a couple like subtle things, but whether we sedate or anesthetize these dogs. And so we always see them the day before. And actually the last three, I think that I've brought in have had, they're older dogs. This was an old lab mix, had probably aspirated the week before and had LARPAR. So while we don't always want to put them under general, it's just another, because I think we think, oh, sedation so much easier. But we have had one aspirate. So we ended up with our team doing general anesthesia for him just to protect his airway. And I think the other thing is, and it's funny, like, because this is the first time I've done it with the AIM being broken, and I'm not sure it was that much harder. I don't know, Dr. C can comment, than when we have the collection preference, because sometimes it's so hard to establish an interface. But one of the things I think that makes it harder is this dog was like, I think I have some videos we could play, like, yowling the whole time. And I think every time he got excited, he probably had splenic contraction and changed his hematocrit. So it added time to the treatment. So it's the idea of finding a really nice plane of sedation, but without over sedating, because if they vomit or have some reaction, they can vagal or aspirate. So, we definitely make it different for different dogs, but I think, including our dog last night, we had the plan that we gave him Torb at 0.1 mg per kg intervals, and then we're going to give him like a wisp of dexmedetomidine because we wanted him quiet, but not overly sedate. And I think the one thing that we didn't get this dog on trazodone the night before, so I think that also might have helped. So we ended up giving him a little trazodone, like nervously with his LARPAR on the machine because we had to pill him. But anyway, I think that's actually an important thing that really affects this treatment. Took a long time because this dog was so wild.
Yeah, and one of the things that just you hate when you're doing cell collections is to have the pump stop, because every time the pump stops, then you lose the interface, and it takes 5 or 6 minutes to get the interface back. And so if the catheter is a POC, as we say, piece of crap, then that makes a long day. And usually dogs that are really active and jumping and moving their heads and getting arterial low alarms that stop the pump, that can be very frustrating and probably worth some sedation in those cases. I mean, ordinarily on extracorporeal procedures, we don't sedate the animals, but in this particular scenario, you get a better product. Everybody goes home a little bit less fatigued, and you get it faster if you make sure that the animal's going to be cooperative with the last one we did. The dog just we didn't sedate or anything, put the catheter in, the dog just sat on the table and slept, and then you don't have any alarms, and you can just collect and collect and collect. But if they're moving around and the pump is stopping, then you're in for a bad day.
Yeah.
So the other patient, okay, I just wanted to add the other patient related consideration that I was warned about is this is my first treatment by like everyone on the team individually. And then now I will do that to anyone that I talk to because I saw it in real time, was that these patients, unlike our plasma exchange patients on the Optia, are receiving a really large volume of the citrate of ACDA. And so Jack ended up, because he had quite a long procedure, he got about a liter of that, and he was on the machine. I don't even know, maybe 6 hours or something.
6 hours, yeah, it was long.
Long time. So he had gone out to potty right before we placed his catheter, but he was a stressed boy, kind of anxious the whole procedure. But then there was a very acute progression of his stress towards the end, about an hour before we were planned to be completed. And that's because his bladder had become massive. He created a large volume of urine from that, all that fluid. He'd also gotten a bolus, I think, under anesthesia, which probably didn't help. So just another thing, we hit him. He was very stubborn and refused to urinate on the table, and we worried about putting him down. So we did for him something that we don't do that often, and just place a quick like a Foley catheter just to drain his bladder a bit so he would be more comfortable. So just something to think about if you have a patient who stays overnight with you and maybe gets let out at 6 a.m. That's not going to cut it. So I was even like, oh, I should have let him out right before, but I don't think there's anything we could have done differently, but definitely to be aware of.
Yeah. And everyone walked in the room, and I think people told him about the urine 17, tell Sarah about the urine 17 times. So like, she knows. And we should comment others who do this too, because so this was my first time without the AIM. And I know we were talking about, this is what the Cope Spectra used to be like for collecting, that you just had to set the hematocrit. And I think we got a good product. So the main goal, and others who do this all the time, because we don't do it as often, is to get a lot of lymphocytes. And they apparently aren't too concerned with the purity of the product, because they can pull those lymphocytes out. So actually we looked back at a bunch of our other collections, and this is one of the highest lymphocyte counts we've gotten. And it's the first time in any of the ones I've done. We always get red cells and platelets, but it's actually the first time, I think, in all the ones that we've collected, I think like 50,000 was the highest white cell count we've gotten, because I think we're bouncing back and forth so much that we got red cells. And when we looked, most of our previous products had a hematocrit between like 2 and 6, I think, somewhere around there. And then platelets were between 2 and 22 million in the other products. But this was the only one that we were just in that white cell layer bouncing around. So I don't know if others can comment. I've never had, frankly, many neutrophils or EOS. So just the way this dog was going, we collected a lot of other white cells, because I think we were just sitting in that white cell layer kind of bouncing back and forth. And Sarah, I don't know if anyone's seen this. Maybe we'll go talk to ClinPath about what those reticulocytes are, if they did a path review, because I haven't done that. I can't think of why there'd be retics, because this is circulating and this dog wasn't regenerative or anemic. Yeah, but this was the product, and I don't know if anyone wants to comment who does a lot of these, but we were happy. And I've never seen so many newts or EOS. But it's just where we were sitting in the monolayer.
Yeah, to get a really pure product, I mean, you have to have a very cooperative patient, and you need to just kind of get that interface established, and it just sits there. And occasionally that happens, but probably more commonly the interface bounces around a little bit, and it goes up and it goes down, and so the purity is not as perfect as you would like, where you'd like to collect just lymphocytes, but certainly a robust number of lymphocytes, about a 15 times enrichment of the lymphocyte count in this dog.
Yeah. And I was going to say, and then, I always like to look, it's sort of like, I think back to when we get hemoabdomens and the student will come and say, oh, we collected with the resident, the sample looks really bloody. And a lot of times there's only 3% red cells. So this was higher red cells than we usually have. But I think when we calculated, we got 150 mils of product. So it was, Sarah, what did we say? It was like 25 mils of blood or something, of red cells, which isn't ideal, but this was like a almost 50 kilo dog. So not going to affect him. And his, obviously PCV was fine several hours after, and his CBC looked good. We rechecked his CBC, but yeah. I don't know if anyone has other comments or anything else.
You said I'm not doing cell collection yet, a big yet. But is that 6 hours? Was that more of a result of him bouncing around, or is that typically, the timeline these guys take?
I think it varies. I think most of ours have been closer to 3 to 4, so it was definitely longer. And part of it is, and again, Dr. C can comment, because I was not here when the camera went out at the last collection. So it's the first one I've done without. I think what happened was, to get the interface, to get a good interface, it took us probably like an hour and a half to really get a good interface. So I think that was the biggest part without the camera. So it definitely probably was, I think, about 2 hours longer than a lot. But we've had some with the collection preference working where it just bounces. They move, the catheter's not working, and then every time that happens, it disrupts the pressures, and then your interface gets goofed up, and you have to reestablish that interface to be able to collect. And we were talking the splenic contraction. We know that fluid shifts always happen in this guy's. We didn't have to bolus him or do anything, but I think It was longer than usual, but I think it can take a while when that interface is goofy with a bad catheter or something, or catheter is not working.
Yeah, there are a couple of things that will, and I agree with what Dr. Palm said, but there are a couple of things that will dictate how long the procedure is. One is what your starting lymphocyte count. So if you start with a patient, which we very often do, that only has 600 lymphocytes, then it's very difficult to collect them, because and it depends on so the time that you're going to be on the machine is going to be dictated by the volume of the product that you want to collect, and we usually try to collect a minimum of 100 mils. But if you can only collect at half a mil a minute, you know, that's gonna affect how long it is. And we usually start collecting really slowly, because the other thing that you might recognize, you're collecting an individual layer in the buffy coat. So you got a buffy coat that maybe is this wide, and the lymphocytes are sitting in a tiny little layer right there, and you might collect them faster than they're building up. And so you're collecting, and all of a sudden the product is right where you want it to be, and you suck all those lymphocytes out of that layer, and then it drops down and starts collecting a deeper layer, so the product gets deeper. Then you have to send those cells back to the patient because they're not the cells you want in your collection bag, and then you have to wait for that lymphocyte layer to build up again. So one problem is the rate at which you can collect those cells. This dog had, he started with probably more than twice the lymphocyte count that we ordinarily encounter. Made it a little bit easier, and at the end we could actually collect pretty fast at about 0.8 mils per minute. But then sometimes you have to manipulate the machine, get the blood flow to go faster so that you can build up that lymphocyte layer faster so that you can collect faster. So they usually take 3 or 4 hours typically, I think, but with a real, that's if a dog is very cooperative and the lymphocyte count is appropriate, all those things, those are ideal conditions. But if you're getting stops and starts in the machine, and the interface keeps coming and going and coming and going, and you have to keep reestablishing that very transient, tiny little layer that you're trying to collect from, then it can be longer.
Yep. Sorry, Jethro, did that answer your question?
Yeah, no, that was perfect. Thank you.
I was going to say one other thing that I haven't encountered actually as a learning point was because it was taking a long time. And you guys remind me, I think we started his inlet ratio at 8-1 because we didn't know how cloudy he was going to be. So of blood to citrate, we were at 8-1. And because it was taking a long time, and I just thought of, as I was sitting here, another way we could have faked the machine, we started to get a warning that the machine was going to end the treatment because we were at our limit of how much ACD it would let go back to the patient. And obviously we were giving calcium to him, actually not a huge rate, frankly, but calcium to him, calcium gluc. And I think we were at like 0.5 mil per minute per kg or 0.5 mil per hour per kg for a while. Anyway, so the machine though was like, we're not going to let you finish this treatment. So that points that probably was one of our longer. So what we did was we increase the cell collection rate. So the amount of cells that are going to the collection bag per time. And then because we had no clotting, we dropped his inlet ratio from 12-1. So he was getting less basically ACD back per time. And I was just thinking, I think that, and not that we'd want to unsafely give him too much citrate, but we were watching carefully, we were giving calcium, his volume status was fine because he was a huge dog, was we probably could have increased his, I bet we could have increased his weight in the machine as well. And I wonder if it would have let us give more. If I was thinking of if we get faced with that again and we get in. So yeah, because we were almost getting told we weren't going to finish the collection because it was not happy with the amount of ACD he'd gotten.
The Optia machine for plasma exchange and for these collections, it has some thou shalt not exceed, and those are volumes. So it's not going to let you raise the blood volume either too high or too low. And I think a 25% increase in blood volume as the machine recognizes, and you've given enough, you tell the machine what the blood volume is, and then you've given more fluid. It knows how much fluid you've given during that treatment, and you get to 125% of blood volume, and it's going to say, I'm sorry, the treatment is over. And it does the same thing on the low end. If you're removing fluid, it will let you drop the blood volume about 15%. And those are hard stops. And once you hit that point, you're done. The machine's not going to let you do anything else. So we actually had this low AC ratio at the beginning. I thought I had a picture here. We had a little clot in the system, and I don't have a picture that shows that. But there was a little red clot. Sometimes you get white clots, and sometimes you get red clots. And there was a little one right in front of the well, I'll show this picture because it's close enough. Right. Well, I can't because I can't find the. Here, we'll share. Right here, there was a little red cell clot that we could see early on in the treatment, and so that was kind of an impetus to keep the AC and the AC ratio high at the beginning. I mean the AC ratio low, and that means more citrate than blood. 8 mils of blood to 1 mil of citrate, as opposed to 12 mils of blood to 1 mil of citrate. And that would be appropriate to do at the beginning. And that clot eventually dissolved. And then we just didn't think. And so it was a learning curve for both Dr. Palm and me, because I hadn't experienced that before either, that we should have dropped the AC ratio earlier once that clot dissolved. If you have a clot right here, it's hard to collect because you'll get a wave over the clot, a wave of the cells over the clot, and then it makes it really hard to collect where you want to collect.
Dr. C, will you leave that up for a second? Because I think another good learning point was that, so the packing factor for the cell collection is 4 to 5, 4.5, something like that. So the cells are way less compacted, where when we do TPE, which we do way more commonly, the machine is like rocking because the centrifuge is going so quickly, because the packing factor is like, I think yesterday it was only 25, but it goes up to 40, I think, right? Between 25 and 40. And so it's not real, but so it's interesting how different the interface looks, because it makes sense with the low packing factor, the red cells, when we have a nice interface, are literally sitting at about halfway point, where you'd think like the dog's crit is 40% when we set it towards that. Whereas I think, Dr. at the beginning, do you have one where we couldn't understand why it was taking a while to get the interface, where it's all plasma that you're seeing? So when the yeah, and then this for like a TPE is what it looks like, because the packing factor, it's spinning so fast that all the cells are like jammed at the bottom. So that was kind of fun to have done the mononuclear and then the TPE yesterday, because Sarah was like, oh my gosh, the machine is like whapping, and I never thought about it, but how much faster the centrifuge is going for a TPE collection, and how the interface, when you get what you want, looks very different.
Yeah, and so this little thin line that you have down here is all the red cells and all the white cells compared to this. So here's a group of platelets up here at the top, this kind of gray, and there's a little bit of plasma, right? A really thin layer of plasma. So this interface is really wrong. But the buffy coat, as opposed to a plasma exchange, the buffy coat is spread out from here down to here. The red cells are coming on this little tiny channel right down at the bottom. So by packing very slowly, then you spread out the buffy coat over this large range, and the lymphocytes are going to live kind of right here. I was talking about this layer that you're collecting. So, well, they're going to be right kind of at the surface here, because the platelets will be at the top, and then the lymphocytes will kind of be in here, and then you get into monocytes and granulocytes and stem cells and other cells down here, and then ultimately down into the red cell layer. But where you want the interface, where you want to collect the cells that you want to collect, and for lymphocytes, they're going to be right at the top of this interface, and so you want that kind of right in the center. So that's,
and for Jack's
plasma.
treatment too,
that's cell collection.
Yeah, and it went well. Jack tolerated it really well. But it was interesting, and I when I brought this up to Sean too yesterday, we didn't know why, because you said, and that was Sean's impression too, that like the machine should have a hard stop with volume. With him, maybe just some of the adjustments we made, it ended up being a final of 141%. So rather than the machine stopping us from doing that, it seems like we were able to override that somehow, which for him, I think a large dog, I think it was totally fine, but
I thought
I'm not sure how that.
147 was the cutoff sometimes. It's not always 25. I think we were getting a
Oh,
cutoff of
okay.
147. I think that's
It
why.
may depend
Like,
on whether it's plasma or because this one, it knows that it's mostly crystalloids that are going back to the
Yeah.
patient. And so it probably counts for plasma exchange where you're giving plasma. I think the cutoff is closer to 125%, and
yeah.
then
That makes sense.
about 85% for the change in blood volume.
That because
You
the
know what?
machine
Oh,
the machine accounts for the citrate that's in the plasma product going back, or is there another reason?
The machine knows this. The machine knows exactly how much volume is going in and exactly how much citrate, because you tell it what product you're on plasma exchange. You tell it what your replacement solution is. So when you're giving saline or you're giving saline or colloid, synthetic colloid, the machine will run at 146 mils a minute. I mean, it'll just scream because there's no citrate. The only citrate is what you use to anticoagulate the machine, and most of that goes up into the waste bag and doesn't go back. 80% of it goes to the waste bag, doesn't go back to the patient. But when you start plasma, which is 15% citrate, then the machine goes and goes, it'll drop down from 100 mils a minute down to 20 mils a minute because it knows the rate that it can safely deliver the citrate back to the patient. But it
you have
also,
to
in plasma exchange, you also have to set what the fluid balance is. And so the fluid balance is essentially the blood volume balance. And if you set that, you say you want a positive fluid balance, and you tell it that you're not going to do a rinse back where it's going to collect some cells. It knows exactly for the mil what the fluid balance is in the patient. And as it starts approaching the maximum, the machine will start to warn you that you're getting close, and then you have to make some adjustments. But those are hard stops on the machine is the fluid balance for the patient.
And the other thing I'm curious whether have, so whenever we have like sick patients in, I like, and they're in hospital, I always like to have a central line that we put our calcium gluconate back in that's separate from the extracorporeal circuit. For these dogs that are coming in and don't have they usually just have a peripheral cath from their sedation plus their extracorporeal catheter. We run it on the venous side. So we put a 3-way stopcock, and that's where we run the calcium gluconate, which is totally safe. And honestly, it took me a while because I didn't like the idea that if the venous side wasn't working and we had to like flush the catheter in, then we'd have calcium gluconate and there would be flushing in. So there's some risk and we're careful with it. But I think that's another thing that I've finally gotten comfortable with is running the calcium through basically the extracorporeal catheter for 2 reasons. One is that means that your venous side or return in appropriate terms is not anticoagulated as well because it's gotten calcium back. Plus, like I said, if like your catheter is not working well and you have to stop treatment and unhook and flush, there's that volume of calcium gluconate dissolved in there. But for these treatments for the dogs that are like essentially outpatients, I never feel comfortable running the calcium gluconate for risk of tissue damage to a peripheral cath.
And this machine's different than what you may have learned about doing plasma exchange on a Prismax or an Optia. When the blood pump stops, the citrate pump stops as well. Where on those other platforms, you're delivering your calcium stops as well. Where on the other no, that's not true. We run the calcium on a different pump system. So when the machine stops, then you probably do have to worry about, like on the Prismax or the Prismaflex, you have to worry about stopping your calcium infusion, which we're probably not as good at doing that as we should have been.
Yeah.
But the citrate does stop, as opposed to other machines where maybe the citrate continues to flow.
Yeah. Or if you're faking out like another machine.
Yeah.
It's like, yeah. Well,
So that's cytopheresis, fun and games, and I hope Sarah appreciate it. Generally, these are fun procedures. I mean, they're really cool, and they're just fun to do. Sometimes they're a little frustrating, but when you look at the what you've done at the end of the treatment, then it's really gratifying. Anything else? Any other questions or comments or other patients to talk about?
That size catheter and that dog gets you all the flow you need for this procedure. I thought you could talk about a 14 French or something. That's my go.
Well, you're not going to flow faster than 30 mils a minute on these procedures. So even on a huge dog, that catheter is plenty good enough. Sometimes on a big dog, we'll even put an 8 French in. The 8 French usually aren't long enough, so I think this was a better choice for this dog. But you're never going to flow faster than 20 or 30 mils a minute.
We can talk briefly. I mean, if everyone's done or doesn't have comments, we did treat this dog yesterday, and honestly, some good discussion points. So we had a dog yesterday she had 11-month-old poodle mix doodle of some sort, who got into supposedly, and so this is almost part of the discussion, I like to say, supposedly 3,000 mg per kg of ibuprofen. And her local vet was awesome. It happened sometime between 9:45 a.m. and 11 a.m. yesterday, and she was at the vet by 11:30. They decontaminated her with vomiting, gave her activated charcoal, and gave her intralipid like right then. And so we got the call, Sarah, I think around 2 o'clock, that they maybe wanted to come to us. And so it had been at least, let's say 10, 11, 12 to 1 month. She had been 3 to 4 hours, and she had 0 clinical signs. And we re-looked this up because I was like, I'm pretty sure, but I'd love comments from others that when the dogs have gotten into that high doses, they are starting to get neurologic within like a couple of hours. So we were almost 4 hours out, and she had no clinical signs. And so they said they wanted to come in. So we said they would see her, and we made a decision. We're like, well, we'll talk to them. And they came in, and so you comment, but I think her creat had been 1 when she had gotten to the local. And then when she was here on our ICU machine, it was 1.3, and her pH was normal. So my gut, and this is my hardest decision, is like, is it worth the cost? Low risk, but we've had some that are GI bleeding that we give heparin that bleed worse, and, other complications. And so so she came in, her pH was totally normal, and long story, we talked to the owners, Dr. Michalak did, while I was running around, and they made the decision to want to treat. But one thing is like making the decisions in these dogs when we don't have, online or bedside measuring, because my gut is that they probably decontaminated her well, whether she got the dose they said they thought she got, that with a normal pH at that dose and 0 clinical signs, I'm hard pressed to think that she had really high levels. So I'm just curious if anyone has comments on that. We treated her.
Acetaminophen or ibuprofen?
Ibuprofen, 3,000 mg per kg. Yeah. And I think after 500, I think it's been pretty reliable. That's where we truly start to see neuroscience in the ones that have actually gotten that dose, but just curious.
So one thing I can say is we've just submitted the guidelines for the hemoperfusion guidelines for treating toxicities, the IRRS guidelines, and that's related to hemoperfusion. But one of the guidelines was that if it's a witnessed or a known exposure, and the animal is still asymptomatic, probably the recommendation is to treat. Because you may not get a second chance. If it's an unknown or unwitnessed exposure, and the patient comes in without clinical signs, then you might be recommended to just follow the patient for a little bit longer. So those guidelines will be coming out soon. They're probably going to be out as an e-publication before they're out in print. So hopefully they'll be out soon.
But I think since it's not always black and white, this dog was like appropriately treated immediately. So whether they witnessed 3,000 mg per kg and she was decontaminated to 50, I think that's the balance, is that there's so much, and we treated her, but like, and most of them do well, but we also have the ones who are ulcerating out, and we either try not to heparinize a lot and they clot, or we heparinize a lot and they are bled down to a crit of 10, so I think that's the discussion we always have.
Yeah, well, it's a difficult
But-
decision process. It always
So we did decide, because if she did get into it and she'd gotten intralipid, and this is another question, maybe for some of the critical care crew, is we saw her, we got her on the machine at like 7 o'clock last night, maybe ish.
Yeah, about
She
7.
was on the machine by 7, and we did decide, because of the bleeding risk potentially, and because she got intralipid, to TPE her. We were ready to carbon, and then we just made the decision to do that because they didn't have any financial, and her serum was totally clear at that point. So I'm curious for maybe the critical care crew when they get intralipid, because I see them later. We've only TPE'd one dog post intralipid, and I don't think we've given carbon to anyone. So that was the other question, is because I've never done carbon on an intralipid, and I know how hyperlipidemic they can be after. How long does it take to clear? Do you guys know? She got a good dose, and she had like her serum was at least visibly clear by 7 o'clock that night. They usually clear it quickly, Jethro, or
I'll make one comment on the carbon and the interlipid.
Yeah.
So I have treated some of those, and what it turns out is the carbon actually removes the interlipid as well.
Yeah.
And so the option would be, if they come in already with interlipid and you're using carbon, then you actually remove that lipid, and that would give you the opportunity to redose the lipid if you felt that it was appropriate.
Sure.
It doesn't interfere with the carbon, apparently, or the absorption.
Good. Thanks, because we didn't know that part. Jethro, were you going to say, or Reineke, like what the?
Yeah, I mean, it's so variable, it seems. I just submitted some samples for ibuprofen levels and a carbon dog that we did treatment on, who had received intralipids, and the serum was completely clean. Nothing there. And through the
How
treatment.
soon after? Do you know?
I was within a couple hours. I think
Okay.
they treated another hospital and
Good.
came down to us, maybe 4 hours at most.
Okay.
Whereas I've had other ones that have been longer than that.
Around, right? Okay.
And there's still, a little bit lipemic at that point. So I think there may be some patient characteristics that kind of go into that too. So I've been struggling because a lot of mine do get intralipids beforehand, and then trying to measure levels of toxin after the fact is interfered with by all that lipid.
Yeah. Cool.
I was just
So-
gonna agree with him. I have the same
Hi,
experience.
Reineke.
Hi. I think it's just patient dependent, really patient dependent. I'm not surprised it was cleared, but I wouldn't be surprised if it was still lipemic. Yeah.
So anyway, so we treated this girl. She was perfect on the machine. I don't know if there any good learning points. She was pretty straightforward. Yeah, I don't know if there are any. Really, she was kind of an easy one compared to Jack.
And then you guys did centrifugal again?
Yeah, we did. I honestly too, because we rarely use the Prismax since we have the Optia. And I know in theory the lipid I don't know, Doctor, have you done it, or have you guys done a post intralipid on the Prismax TPE? I'm just curious because I also haven't done a filter based TPE after intralipid.
We had one. We discussed this on one RRR maybe a year ago, and the person that had the dog had been given her lipid, and they got a TMP alarms. I mean, it just clogged
worried.
the whole membrane.
Okay.
And I think others have done plasma exchange on dogs with interlipid and haven't seen that, but I think that would be
A
that would be
potential risk,
concern,
right? Okay.
that you would clog the membrane. So I don't know whether, apparently it does and it doesn't. So
Okay. Thanks. I wasn't sure, so we didn't. Yeah.
I don't think I would use a membrane do a membrane TP on a dog that that had lipid, because you just have the risk of clogging the whole circuit up. And this was a specific clogging, so the TMP went up, but the delta pressure didn't go up. So it wasn't a clotting situation. It was a clogging of the pores.
I wonder if that was your only option. So I don't have centrifugal, but I would probably do hemoperfusion instead. I'd choose that, but maybe just dropping that filtration fraction way down if you had to do membrane based and they were lipemic. Do you think that would help with the TMP getting and the pores getting clogged? I mean, I'm not saying it's ideal by any means, but if that was my only option, maybe that would be something I might try. I don't know.
I think it might, I wonder, and I don't know if it's like more of like an adsorption thing, because it's like, this might sound really silly, like sticky versus clogging, because it should fit, I think, but but it still might
no,
fit it out.
those my cells, because I've looked this up, they're 300 microns. They're big, and so they're not going to fit in the pores. And I think changing the filtration fraction, you change filtration fraction to prevent clotting, not clogging. So you just got a big gooey substance that's going through those pores, and it's gonna plug up the pores, and that's what's going to change the transmembrane pressure. But the delta pressure would change if you're actually obstructing the tubular lumens. Well, that's very good discussions today. Thank you, Sarah and Carrie, for that contribution.
It was fun. Thanks, Dr. C.
Those contributions.
I've got one last question then. That was Sarah's first experience with an ECT treatment?
Well,
when she was a resident.
She was our resident, so I kind of forced her to stay with us, but her first
She was the resident queen for extracorporeal. She had more patients than anybody.
Awesome.
Yeah, but my first experience, it's very different, focusing on the, I was more on the patient side and then taking in as much as I could while I was running around as a resident. So really cool to be the one running machines. Super exciting.
Be sure to log that procedure so you get you get credit for it.
Thanks, everybody. Nice to see you. Have a nice weekend.
Jethro, you want the last comment?
I had my finger on the button to leave and it wouldn't let me unmute at the same time. There's my last comments. Yeah, have a great weekend, everybody. And thanks as always for helping us all learn and get better at this.
Yeah. Good comment. See you next time.
Bye, guys.
Bye.
Thank you.